Wow. Welcome. Welcome to everyone as you join us for the Health System Performance Network monthly webinar. Very happy to have all of you joining. We're actually a few seconds ahead of 12, um, which is awesome because I can see people who are already anticipating. The room is filling already. That's really, really great. I would encourage everybody, please, if you can open the chat box over there and make sure that you click and send your note to everyone, and let us know who you are and where you're from. If you're from an Ontario Health team, let us know which one, and otherwise um, where you're joining us from, what organization, or just where you are, perhaps provincially, nationally. There's Calvin Young from Thunder Bay. Welcome. Christine Olson from Mississauga. We'll be highlighting some of the work from Mississauga today. And Christine, it'd be great to see. Um, Lyubov from Kai. And now people are coming in furious and fast to the point that I cannot possibly keep up, but I will call a few people out. Shelley is joining us, and she'll be part of the speakers today. From Ottawa, OHT, Chantal Leduc, also from Esso, Cochrane District, OHT, Shakil Ahmed from Runnymede in Toronto, Amandeep Kaur from Brampton, welcome. Uh, and we have Al Sayed from the QUIDS and IPHCC. I know that acronym, but it's just passing my mind right now. I believe that is the Indigenous Primary Health Care Council. Welcome. I'm very, very happy to have you with us. Um, Chris from Care First, Gamal from Ottawa Four Rivers, and welcome everybody. So please keep introducing yourselves in the chat. It is really, really our pleasure to have you here. Welcome back, Helen Lung, who's one of our most regular participants in these. Helen's the CEO at Care First. Really appreciate your joining us today. Um, Darren from Windsor, Essex. So people from all over the province of Ontario, many of the Ontario Health teams, Kelly Kay from the Provincial Geriatrics Leadership Office joining us today. It's my pleasure. I'm hosting this today from the University of Toronto, and I'd like to acknowledge that the land on which the University of Toronto operates has been the traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit for thousands of years, time immemorial. And today, it's still the home to many Indigenous peoples from across Turtle Island. We and I am very grateful to have the opportunity to work here and participate in our shared community. And many of you are joining from many First Nations. Toronto is also home to Treaty 13. And you are joining us from many places in the province. I'd like to open up. We do like to open up with a bit of a poll. We have a good audience today, and to know whether you have participated in this webinar, the HSPN webinar previously. So please let us know if you have, and you can just let us know, click that little box, submit. And this is an easy question that we know everybody can participate in. And so we can get pretty, people are very fast. What amazing responses. We have almost 100% of everybody is actually in here, quite high participation rates. And we cleaned up our email list in the fall for people who had participated in our webinars before. And I also know that people had forwarded this one along to others to join. So we could share this poll now. And we can see that almost half of the people here today are joining for the first time. Slightly more than half participated previously, but for a first event, that is fairly high. So I welcome so many of you. And we do this every month, at least 10 months of the year. And really, really pleased to have you join us today. And so we can take that down, and we're going to move into some of our opening remarks and introduce you to our panel today. Many speakers from different organizations and representatives today. So I'll be your host. My name's Walter Wojcik. I'm the principal investigator for the Health System Performance Network and have been leading the network since 2009. Vijay Kunaratnam is research officer with the Health System Performance Network. She's leading our quantitative analysis of health equity, along many other indicator reports, survey analysis, and so much more. You have a chance to hear from Vijay on our latest approaches to health equity measurement. We're very pleased today to have Ian Cummings, who's the director of the Ontario Health Team Strategy and Performance at Ontario Health. In this role, he leads the measurement of Ontario's 58 OHTs and primary care networks. He has over 20 years of health experience with roles in integrated care, digital health, and virtual care. I'm very pleased to have Ian coming and telling us what Ontario Health is doing in this space with their dashboard and how they're supporting Ontario Health teams. Then we have Eric DeProfittis and Dare Crawford from the Mississauga Ontario Health Team. Eric's the Population Health Analytics lead, where he provides advanced data insights to the hospital leadership and to the Mississauga Ontario Health Team with the aim of improving community health outcomes. He has years of experience. He has a master's from U of T. He's been at Ontario Health and also at CIHI using data and analytics to drive transformation. Dare Crawford is Senior Advisor Population Health, Performance Analytics team at Trillium. She supports the development of the analytical tools to facilitate data-driven decision-making. And they're going to talk to us today about the dashboard and metrics that Mississauga Health has produced, but they've also produced online maps, something called Our Community Tool, which is similar to what you'll see from Shelley in Ottawa. So Dare's been doing a lot of work. Finally, Shelley from the Ottawa Ontario Health Team, Équipe Santé Ontario d'Ottawa. She's the decision support lead, brings a strong equity lens in health planning, grounded in a Master of Public Health and hands-on experience with the Ottawa Neighborhood Study, which you'll see some examples of, and 5 years working directly in harm reduction with unhoused adults. Today, Shelley will be helping and sharing insights on targeted health planning grounded in community equity data. So what an amazing panel to talk with us today, for us to share different highlights of what's happening across Ontario for measuring health equity. And I am really pleased to see some more chats and people joining us from Scotland today, and also West Coast Ireland. So some of our joiners from overseas. I hope you'll find today we were picking up some of the work that's been happening overseas. So maybe you'll see some highlights here. Overall today, the agenda, we're going to talk about why and how health equity is being measured. We're going to talk about what we at the Health System Performance Network have been doing in measurement reporting of health inequities, version 1, 2, and 3. So how we started, where we moved to, and where we're headed now. In version 3, Ontario Health will talk about their dashboard and the Slope Index using material deprivation. Ontario Health Team approaches will have examples from both Mississauga and the Ottawa teams today. I welcome you all to join in. So I'm going to start off with a little bit of grounding on why and how. This here is on the left, you'll see a schematic which represents the material deprivation in each of the Ontario health teams from across the province. So up at the top, we have a team that has a fair bit of dark blue. That is the highest material deprivation quintile. So they have almost over 40% of their population are living in the poorest neighborhoods in the province. And relatively few, less than 10%, are living in the kind of highest quintile. And then we see all the way down at the bottom where it's sort of the opposite. We have a few areas and OHTs in the province where most of their attributed population, or at least half, are living in the highest deprivation quintile 1 to the highest socioeconomic status. So we see quite a bit of variability. And one thing that we've been wanting to understand across time is whether OHT's performance, we have a lot of improvement indicators, and their performance on those indicators might be related to some of these underlying factors of social determinants of health. And so we have what we've been using, and others today you'll see the same. I've been using the material deprivation score, which is one of 4 scores in the Ontario Marginalization Index. And it includes, it's an aggregate score that looks at the population without high school, families that are lone parent, proportion of total income from government transfer payments, those who are unemployed, the proportion of the population low income, and living in dwellings that are in need of major repair. So it's a multidimensional construct that we use to understand whether the area has material deprivation. I see I keep an eye out, and I might be looking at. We've done this at the dissemination area, or the DA level, and then we have the proportion of the population that are in the DAs. We've done it differently. The work you'll see from VJ today is done with aggregate dissemination areas, a slightly higher level due to sample sizes on some of the indicators. So first off, why? Why should we be doing this? Well, there's plenty of evidence that there's strong socioeconomic and health system equity factors that lead towards lower health outcomes. These relate to individuals' knowledge, time, and the resources that are available that affect people's ability to access the right services at the right time. They include, preoccupation with income security. People are, concerned about housing security, food security. They may or may not have access to transportation, may or may not have primary care attachment. All of these are factors that are affecting people's ability to obtain and realize their health gains. And understanding where medical access and quality and where other socioeconomic factors might be playing in can be important to direct the health system, and specifically for our examples today, Ontario Health Team Action towards partnerships and intervention. Providers, physicians, nurses, hospital administrators, primary healthcare teams are really doing a fantastic job of managing people in their clinics and healthcare settings, but very, very often we're finding people need other things beyond medical services. And that's where the partnerships and intervention. So here we're trying to highlight in what ways that impacts on the health system and what we should be doing about it. So a little bit of grounding on health equity measurement. There's three things that you'll hear about today. One is an indicator. So how are we measuring health system performance? You're going to hear a lot about ambulatory care sensitive hospitalizations, or ACSC hospitalizations. You're going to hear about cancer screening. It's cervical cancer screening month, so we're going to have examples there, but also PAP and colorectal, others. Those would be the kind of indicators that we're looking at. How well are we managing our health system? Then we have something that is a stratifier. And this is our equity, how we measure equity. Well, I talked to you just now about material deprivation, but it could also be done with income, education, immigration, race, primary care models. So there are many things that we could think about stratifying. And then we can think about how do we take these two and analyze them together to understand health equity and how it affects on our performance. And you could do that just simply with stratified analysis. You could do it with a ratio for the highest to the lowest quintiles, perhaps. A slope index of inequality we'll introduce and talk about today, and also a relative index of inequality, and how different measures and approaches can inform your work. And so we have here, I'll do a quick little intro on some of our descriptive, just about 4 or 5 slides of what we've been doing back in 2020 when we started this work. We would lay out, for example, these are charts from our first reports of Ontario Health Team performance. Each dot on this chart represents an Ontario Health Team. On the left, you see the scale, which is here, it's the hospitalizations per 100 for ambulatory care sensitive conditions per 100,000 population, ranging in an average of about 300 and a bit. And then you see there's quite a bit of a range of the rate of hospitalizations from down around 150 per 100,000 in OHT 13 up to over 550, almost 600 in those 3 OHTs you see up there, 10, 40, and 19. And what we did here to understand a little bit about this equity ratio is, one, to look at the correlation. So you see down on the bottom, the correlation with deprivation, and you see there's like a 0.43, which is a moderate tau index. So not super high, but also not low. It's definitely there. And the other thing we did is we colored the OHT dots by the relative ranking of what proportion of their population were in the most deprived areas. So the dark dots, people were in the top quintile of having most of their population. And so you see the darker dots are up towards that higher end of the spectrum for the most part, not universally, and mostly the lighter dots down to the left. So this is how we first got a bit of a sense that there is something going on here outside of what the healthcare system is doing. And areas with material deprivation are much more likely to be having people going to the hospital for ambulatory care sensitive. So these are things like CHF, congestive heart failure, pulmonary respiratory diseases, diabetes, and other potentially conditions that can be managed in the community. We also did this looking at emergency department visits here. So you see a little bit more of a flat line, but also still a little bit of more inequities, suggesting at the top it's not as strong a relationship as it was for the ambulatory care sensitive conditions. So that's how we did things on the first. The other thing we did back in 2023, the last time we put out reports, is we started talking about more pointed work using our indicators. So we had these presentations, every OHT individually. These are available on our website. There's a presentation, and then there are 3 Excel files that provide every indicator, 27 indicators, stratified by material deprivation, as well as these segments. Neighborhood material deprivation, as I said, primary care enrollment models. We also look at different health conditions, people in the CHI POP grouper, and also by the BC Health System Matrix. We've got webinars in the past where we've talked about those. But we do these to understand people with which health conditions and in which areas of deprivation do we see performance varying. And here's one of the things we had in our decks before. So this is ambulatory care sensitive conditions. This is for all of Ontario. Each Ontario Health team has this result. And you see here that 521 per 100,000 person years in the areas of highest material deprivation is like 3 times higher than it is down in the areas with the lowest material deprivation. So really quite a very stark contrast across these. We did also look at other indicators. And so this one is ED visits. You see not quite, it's up 4 and 5 are quite similar. And then there's a gradient coming down to Q1. And this is a PAP test for cervical cancer. So you see here lower, so it's a different direction here. So the areas with the highest material deprivation here have the lowest achievement of having up-to-date tests, 49%. And then it's 60, almost 61% in the areas of the least material deprivation or the highest socioeconomic status. This indicator goes in a different direction here. So we want more people. And here we see that areas of high material deprivation are falling behind. Also true of mammograms. Similar range, like a 13% difference. So here makes us think, what are some of the access issues and other issues that might be related here? But we could look at things that are not straight up in this linear dimension, such as material deprivation. And this here is about primary care rostering. And I know that people are interested in rostering. And so we see here, for example, this is mammogram results. People that are not rostered to a family physician at all have a 46% being up to date on their mammograms, whereas it's 68 or 66 in the capitation models and family health teams. And it's at least 60% for anybody who's attached. So quite a gap just having that attachment. That's what we've been doing in the past. I'm going to turn it over now to VJ. I see some questions popping up in the chat. I think I will probably just try and answer those a little bit on the fly. And we'll stop for some other questions after VJ has been through her slides. Welcome, VJ. Over to you.
Thank you, Walter. Thank you. Hi, everyone. So my name is VJ, and I'm going to spend a little bit of time talking about the slope and relative index of inequality. So, Walter just walked us through some of the work that we've been doing at HSPN, and I'm going to give a little bit of a preview of where we're heading towards in terms of equity analysis. Sorry. So as Slope Index of Inequality, or SII, it's basically a way for us to summarize the absolute inequality gap for outcomes like ACSE hospitalizations or ED visits across the whole socioeconomic spectrum. So we're not just comparing the very top and the very bottom. We're really looking at the distribution between as well. And so how we do that is we rank each population subgroup. So as Walter mentioned, at HSPN, we're doing our analysis on the OHT ADA level from least deprived to most deprived based on material resources. previously known as material deprivation, as many of you were probably familiar with. And then we look at how does this outcome change as this deprivation increases or decreases. So the SII does come from a population weighted regression. So larger ADAs do have more influence on the analysis. And the key thing I wanted to point out here is that the result is in the same units as the outcome. So when we're looking at something like ED visits, the SII is telling us the absolute difference in rates between the most and least deprived areas. So which makes it pretty intuitive for us to report. This is an example looking at, rates increasing. So on the x-axis, we have the deprivation quintiles that Walter was referring to. And when we go from left to right, it's increasing. And this is kind of showing us that residents that are living in the most materially deprived areas are experiencing a higher rate of this outcome. I wanted to spend a little bit of time talking about the interpretation of SII and the directionality of it. So the direction of the indicator and the stratifier really determines the interpretation of the actual slope index. So for example, let's take a look at something a little bit more intuitive. Sorry, I'm just gonna go back up. Oh, um, Sorry. So let's take a look at, for instance, like hospitalization rates. So at the bottom, where like higher rates are less favorable, right? We don't want higher rates of hospitalizations. Depending on how the equity stratifier is ranked, interpretation of the directionality changes. So if we have, let's say, if higher means more resources, so deprivation was ranked from most deprived to least deprived, then positive SII is pro-equity, which means more hospitalizations are actually happening in less deprived areas. Whereas if higher actually means less resources, so at HSPN, we've ranked our deprivation from least deprived to most deprived, then positive and significant actually means anti-equity. So more hospitalizations are actually occurring in more deprived areas. So just to go on like what these actual SIIs mean, SII of 0 means perfect equality. So that's across the board, there's no inequity across our equity stratifier. So in our case, our deprivation levels. And then a larger absolute SII means greater inequity. So whether you're going the further you are from 0, whether it's in the positive or negative direction, it just means the larger the inequity. And then moving on to what the negative and positive SIIs are. Negative SII in our case means higher rates in less deprived areas. And then a positive SII means higher rates in more deprived areas. So a negative SII, you're going to see a lot of our cancer screening indicators. A lot of our OHTs will have negative SIIs, which means that there is more cancer screening being done in less deprived neighborhoods. And then again, just to really reiterate, higher rates are going to be better or worse depending on the outcome that we're looking at. And then moving on to relative index of inequality. So this is the relative complement to the SII, and it's calculated using the same regression equation as the SII. So instead of taking the slope, we're taking the ratio between the fitted value of the most advantaged group and the least advantaged group. The RII doesn't have units, so it's not per 1,000, ED visits per 1,000 or years of life. And this makes it useful for comparing inequality across a variety of different outcomes. But when we're looking at it within a certain outcome, it can sometimes feel a little bit abstract. So that's why a lot of the times you will see the RII paired with absolute measures like the SII. In terms of interpretability, so RII of 1 means no inequity, so perfect equality. And then RII of greater than 1 is higher rates are in more deprived areas, and RII of less than 1 is higher rates in less deprived areas. Moving on to our methods. So we included all OHIP eligible patients in Ontario as of April 1st, 2023 for ACSC hospitalizations, just because we used 2 years of data due to low event rates, and then April 1st, 2024 for all of the other indicators. We also restricted analysis to indicator-specific eligible populations. This is the exact same as what we've been doing for all of these indicators in our previous reports as well. So for ACSC hospitalizations and ED visits, analysis were restricted to patients less than 75 years. And then for the cancer screening, we included screen-eligible patients within a certain age group. In terms of our equity stratifier, we use the factor scores for the material resources dimension of the 2021 on-margin index. So in terms of our geographic unit of analysis, we did use the aggregated dissemination area, again, just because a little bit of a higher level because of our rates. And then we also use two strategies to mitigate having unstable estimates or like super large confidence intervals. So the first thing we did was any OHT ADAs with populations below the minimum threshold to yield expected of minimum of 20 events were excluded. And then we also took it a step further and we excluded any OHTs that have fewer than 10 ADAs for our analysis. In terms of adjustments, similar to what we've been doing all this time, all rates were adjusted for age and sex as appropriate. Moving on to our first graph. So here we're looking at ACSC hospitalizations. And just to quickly orient you here, so the horizontal, that is a performance measure that you're used to seeing. So left to right is the rate of ACSC hospitalizations. And you can see there's a little bit of a five-fold variation. So we have, low of just over 100 per 100,000 to just over 550. And with these graphs, you're always going to see the performance of the outcome left to right. And then the new thing that we're introducing moving forward is on the y-axis, you're going to see the SII. So this is what tells us how big the gap is between people living in the most and least deprived areas. So in other words, how unequal are these ACSC rates within these OHTs? When we're really looking at, which corners of the chart are maybe best or worst, the bottom left, that's kind of the worst place to be because you have lower rates, lower ACSC, bottom left, you have lower ACSC rates overall. And then you also have, sorry, that's the best place to be. So you have lower ACSC rates overall and smaller gaps between more and less deprived communities. And then when you look at the top right, that's actually the worst place to be because you have higher rates of ACSC, but you also have larger inequities between the more and less deprived communities. And then when we're looking at the trend line, you could see that there is a clear and strong positive relationship, right? So as ACSC rates tend to increase, you can see that inequities also increasing as well. So this is telling us higher use of hospital care isn't necessarily just a volume issue. It also there seems to be an underlying equity issue as well with this outcome. And then moving on to avoidable ED visits. So this is telling us a little bit of a different story. You see the mass clustering at the low ED visits and low SII right there at the bottom left. And then we also see a few outliers, right? So we see at the top, we have 3 OHTs that seem to have very large SIIs. So those OHTs, they seem to be having higher inequity with areas of higher deprivation having more use. And then on top of that, we also see there are some OHTs to the far right where irrespective of material deprivation, they seem to be having higher rates. So when we're looking at a graph like this and you see kind of the clustering by the median and then a spread of a few OHTs, which seem to be kind of driving that trend line, here's where we can talk about perhaps some targeted initiatives for those OHTs. Moving on to cervical cancer screening. So this again is different from the previous 2 indicators that I talked about because here we want higher screening rates, right? So the optimal number here is 100%. And you can see on the x-axis, the range that we have here for cervical cancer screening across the province is between 45 and 60%. One thing I did want to direct everyone to is the median equity line, which is the horizontal dash line, and that's below zero. So that's telling us that most OHTs have negative SIIs. So across these OHTs, fewer people are having cervical cancer screening in areas of greater deprivation. Another interesting thing about this graph here is you can see that there isn't much variability in the y-axis. Any variability that we're seeing is kind of at that x-axis, right? And the trend line is mostly flat. It's kind of blending in with the horizontal axis. So it's showing us differences in overall cancer screening and the rates of it is not necessarily associated with deprivation related inequity. So there may be other factors playing at play here. Looking at breast cancer screening, so this is telling a slightly different story than our cervical cancer screening. So whereas PAP was kind of clustered at the median, here you could see OHTs are more spread out. And then when you look at in terms of like the quadrants, here the top right here is actually the best place to be because we want higher rates of screening. And then the top right is SIIs are actually closer to zero. So the smaller gap between most and least deprived areas, it's kind of closing, right? And then bottom left is actually the worst place to be. Similarly to PAP, you can see the median equity. So the horizontal dash line that is well below zero, right? A lot of OHTs are having negative SII. So that again is telling us that lower screening rates are happening in areas with higher deprivation. And PAP was a very much a flat line, but you could see here there's a little bit of a shallow trend line, which shows a modest association between overall screening levels and inequity. Moving on to our last screening, a cancer screening, colorectal cancer screening. Very similar story here. All but two OHTs have negative SIIs. So it tells us that, again, across most OHTs, there's less colonoscopy cancer screening happening in areas of greater deprivation. And again, the slight flat to shallow trend line shows us that there is a little bit of association between overall screening levels and inequity. But even with the higher rates of colonoscopy cancer screening, OHTs are with lower screening are still happening in deprived communities. Moving on to our last indicator, our last new indicator I will introduce, percent not rostered. So again, here our performance outcome is on the x-axis. So the higher rates here are the worst outcome. And then our SII is on the y-axis. So this graph here is showing us OHTs with higher percentage of patients not rostered are having higher inequity, right? Even though most do cluster around that median. What's interesting here, there are actually a few OHTs, I think it's 11 in total, that have negative SII. So there are some OHTs that seem to have worse attachment in less deprived areas. But overall, the positive trend line shows that OHTs with poorer overall attachment also tend to have larger gaps between the more and less deprived communities. Okay, we spent a lot of time talking about the SII, so I just wanted to spend a few moments talking about the RII. So as I mentioned, the RII is the relative component, so it takes a ratio of the SII, and RII of 1 is perfect equality, and then when you get further away from 1, it's higher inequity. So here you're looking at the left-hand side is the graph that you've seen before. It's the SII versus the adjusted ACSC hospitalization rates. And then on the right-hand side, we have the RII component to it. So RII versus ACSC hospitalization rates. And you can see here, both of these measures tend to show that higher ACSC rates are generally associated with more inequity. But when we look at the RII in particular, you can see there's a lot more clustering, right? So this is showing us many OHTs, they may have very similar relative inequity, even though maybe their overall hospitalization rates may be quite different. So they may have different, their absolute inequity might be a little bit larger, but their relative inequity might be a little bit more similar across these OHTs. And then I'm just going to end off talking about one more example. So the top there, that's the ACSC hospitalization rates that you've seen. I've just kind of layered on another indicator just to quickly chat about it. So this is the percent not rostered patients. Again, the left-hand side is the SII graph, and then the right-hand side is the RII graph. And you could see here very similar trends you can see at the SI and the RII. If you just want to quickly look at the interpretation, the slightly different interpretation. So for the SII, the dashed median equity line is just around 9%. So that's telling us there's about a 9% difference in the share of people that are not rostered between the most and least deprived areas. And then when we look at the RII, the interpretation is slightly different because we're looking at it relatively. So we're saying, relatively speaking, people in more deprived areas are about 40% more likely to be not rostered because the RII is about 1.4 in terms of median equity. And we can also say that the proportional gap is fairly consistent across the teams just because of all the clustering that's happening across that median rate and median equity. Just some final thoughts here. So what we found with these SII and RAI analysis was ACSC hospitalization and attachment to primary care rostered do show a strong relationship with material deprivation. And then we found weak association. So cancer screening did have a range of OHTs where you could see some OHTs did have some equity gaps. Some were even equity positive, right? So lower SES actually had higher achievement in some of these cancer screening outcomes. And then we found that ED visits were equivocal. That's everything for me. Thanks, Walter.
Thank you so much, VJ. I think you did a really good job of explaining what are, some fairly complex analytics in a fairly quite a straightforward way. So thanks so much. I really appreciate that. Um, uh, there is yeah, I've been answering questions along the side. You might look back to see that I did them justice. Um, Mike Heinmarsh, just near the end here, asked a question that I think we should be raising with all of our panelists today. And that is, if I want to intervene in a population of patients in the Ontario Health Team, do I want to use the relative index of inequality, or do I want to use a slope index of inequality, or do you want to possibly use a different, like even just a stratification, Mike? Because I think to drill down specifically in areas of operations and into where you need to work, these are geographic measures, and they provide us information about geographic differences in people's access of the healthcare system, use, primary care attachment. So I'd try and bring that down a little bit. Shelley's going to show us a little bit how to do that near the end. And I, if you're working on something and you've decided on one particular area to work on, I'm going to say to you that I think the slope index is going to be most useful because you can see inequity and performance in the same scale. So you can say, both you can say, hey, we have 350 per 100,000 people that are being admitted to hospitals for potentially community-based conditions, or we have 17% unattached patients, and that is 10% higher in the neighborhoods of high marginal deprivation. So you can actually make those specific inferences, and you can say, that means it's like 4,000 people or 2,000 people, and you actually get into talking about numbers. And I think when you get into quality improvement, you want to take these as indicators for where to focus, but then the actual work really getting down to more localized interventions and counts. And again, you'll see that these are good areas to provide indications. The nice thing about the RII is that you can look across your indicators and say, which ones do we need to be most attentive to equity in? And that one will help with that. I am going to see, okay, well, we have people answering each other's questions. That is fantastic. I love that. Kate, we are gearing up and stratified by these. Yes, thank you, Kate. Good to know that that's value. It's value to us to hear you say it's a value, so then we know what to do. We are right now planning our next data packages. The Ontario Health team attribution methodology has just been updated. We have recently gained access to those databases, and we will be now analyzing the data for the 57 OHTs that appear and are identifiable in the administrative data. And there may be future ways, but we're looking right now. And so actually, we're probably going to be reaching out to OHTs very soon to see what type of data package will most benefit you. We have heard that teams have used our data packages in the past and found them to be quite useful. They provide different lens over the data that you're about to see from Ontario Health in the dashboard, which is updated more often and provides some granularity. So happy to hear that. As a very long comment from Lydia. Give me a moment to catch up on that one. It looks quite interesting and captures that we don't want to be normalizing, I think, for these. And so I think one of the highlights that we're trying to do here is to continue to highlight. And there'd be people out there that say you should adjust for differences in socioeconomic, and I think that's probably not what we want to do. We actually want to specifically examine issues around there. So I think, and Richard Levensak, interaction with social deprivation with high physician and strong, I'm going to guess, MDs. I'm going to guess that you meant high. Oh, material deprivation. I get it. Sorry, Richard. Where you had high material deprivation and social ties mitigating the material deprivation. So having strong social ties helping. That's really fantastic. And I know, Richard, you've been doing some work around loneliness, and we've started to look at this a little bit as well. So we're very, very keen to see how, these things are not unique. There's intersectionality. Somebody earlier mentioned trauma. That's very true. We've seen a number of comments around gender identity, and I think that's very important for us to be able to look at and understand that it's not just unidimensional across one aspect. That's one of the reasons we actually like the material deprivation, is that it has multiple factors, but it does not capture all. And so how do we better do that? And we're starting to try and unpack that a little bit as well. Any other questions for VJ? I will just pause a moment to see if there's anything else coming up. Otherwise, I'm going to be very, very pleased to turn this over to Ian now from Ontario Health. So Ian, how about you can lead us through the next little bit?
Sounds great, Walter. And hi, everyone. Nice to be here. My name is Ian Cummins. I'm the director of the OHT strategy and performance team. And we're really happy to be here to share the work that we're doing as it comes to equity measurement and data. I just wanted to take a step back. OHTs were introduced back in 2019, and for the first few years, OHTs were asked to identify their own local indicators, and that made sense at the time, given the level of maturity that OHTs were at. But it presented a challenge in that Ontario Health and the Ministry, as the funder of the OHT, really wasn't able to report on progress or measurement because every OHT was using a different set of measures. And so beginning in 2024, we started to transition to and introduce a performance and improvement program that includes a combination of some standardized measures as well as some enabling processes. So we have a set of standardized system level measures, and that's many of them are ones that you've already heard about, like cancer screening or ambulatory sensitive conditions. I do also want to highlight, though, that we are really committed to patient and provider experience measurement. We will be rolling out a provider experience surveys to all OHTs in the coming days. And that survey does include demographic questions that allow us to stratify results by age, gender identity, and ethnic identity, to some of the comments in the chat. Same with our patient experience survey, which we are hoping to roll out a little bit later. In addition, we do have some process measures that are equity focused. We do measure, for example, cultural safety training within OHTs and Indigenous representation on OHT leadership councils. So we have a range of measures that we're looking at, and all types of measures do have an equity focus. In terms of enabling processes, we have begun to roll out quarterly OHT performance reports, and the purpose of those reports is to give OH as the funder an opportunity to review performance with the OHT using a common data set. So I'm gonna talk about what equity data is available in those reports. We do also have a quarterly performance review process similar to many other health service providers, as well as quality improvement planning continuing. So if we just move forward, then go back. So um, Sorry, Diego. I'll let you control it. If we just go back one slide, this is a summary of our OHT performance reports that we are rolling out to OHTs. They do include a dashboard that talk about how performance is trending across a series of measures, as well as 3 years of historical trend data that include some of the equity data I'm going to talk about. The measures that are included are at the bottom. We are, of course, focused on primary care attachment and healthcare connect waitlist clearing, but also continue to have a focus on chronic disease prevention management and cancer screening. These measures were selected in consultation with OHT and clinical representatives and are being reviewed in preparation for next year. If we move to the next slide, I'm just going to provide a quick overview of the equity data that is available through the performance reports. So for each measure, for all of our measures, with the exception of Healthcare Connect, we have included an equity stratification. It's aligned to the same methodology that Walter spoke about previously, so I won't get into it I won't really talk about the methodology itself in too much detail. But just wanted to highlight that for each measure, you will be able to see how your quintile how your values are distributed across 5 quintiles, both for the quarter that you're in the current year, and you'll be able to compare it with the quarter in the previous year. And that data from the previous year will give you a chance to see how the distribution of your results are trending over time. So, for example, in the graph that you see on the left-hand side here for ambulatory sensitive conditions, you can see that the number of hospital visits was greatest in the most marginalized group, the fifth quartile, compared to the fourth quartile, and it does look like it's trending towards greater inequality and greater a less equal distribution compared to the previous year. So with this equity stratification data, we are hoping that OHTs can review it in consultation with their OH regions and really see which measures have the most even distribution across quintiles and where there might be some opportunities to improve performance. And where there is an uneven distribution across quintiles, that can be an indication that there might be some opportunities for some targeted interventions. So I will note that equity stratifications are only possible where we have sufficient amount of data for some of our measures like CHF and COPD admissions, where there's a lower number of results. We may not have values for all 5 quintiles, or may have such a low number of values that quintiles need to be suppressed for privacy reasons. And so we are providing the equity stratification where possible for all measures. In addition, beginning with the Q2 performance report, we will provide SII values, both for the current year quarter or in our annual report for your full year. And we also will provide the values for the previous year so you can compare results. Again, in the previous presentation, there was already discussion about what a negative SII or a positive SIA means. Of course, what you're aiming for is an SIA closer to zero, which indicates that you have a equal result. We do have some limitations in providing SII where there are missing quintiles or for smaller OHTs. And so for that reason, in the Q2 report, SII values will only be included for those measures where we have all 5 quintiles present, and for OHTs with an attributed population of 200,000 or more. Those parameters will be reviewed over time, and if we can calculate SII values for more OHTs and more measures, we will do so. So I'm going to pause there and hand it back to you, Walter.
Great. Thanks, Ian, for that overview. And I really think you've kind of covered off a couple of really useful points here. One is having kind of a common set of metrics that OHTs are looking to and a common way of looking at them. I think that's such an important value of what Ontario Health is producing through the dashboards, allowing people to kind of get a bit of a common resource, a common source for this. And it's been something that you've been building over the last couple of years. I don't see a specific question for you here, so I'll pause for the audience to, participants today to perhaps have any specific, oh yes, there's going to be a couple coming. So while they pop them in there, I got one for you. You mentioned ACSC today. How many of the indicators in your dashboard are you thinking about using? You put up a number on the dashboard there. SII indicators. Do you think they're appropriate everywhere or only for some, or what do you think about that?
So the first step is we have been focused on these parameters where we don't feel an SII can be calculated in a robust manner. So we will have missing SIIs for a number of measures and a number of OHTs. Well, Walter, that's something that we want to review with you over time to see whether SII values can be provided for more OHTs and for more measures. We think that the equity data in equity stratification is important for all measures, except we have excluded Healthcare Connect for the time being, and would be curious to see whether participants feel that Healthcare Connect would be valuable to include if it continues to be a priority.
Okay, great. Thanks for that. There are some questions popping up. Some of them are technical, but I'll say, here's one from Carolyn. I'm wondering if the OHT performance dashboard is planning to be publicly available or still only available to the OHTs.
It's right now our focus is to produce data for OHTs, OH, and the ministry. So we are going to provide you and your region with an OHT specific report, and we're going to take the same data, roll it up across the 58, and provide it to the ministry and our funder. There are no plans at this time to make the data publicly available. Although an OHT could certainly decide to share their performance reports with all their partners or providers, for example, or could even consider posting it on their website.
Yeah. Thanks for that. I am going to pop to one more question and then we'll move on. You mentioned there's a question here about patient-reported experience measures moving forward, and they wanted to know would those be patient-reported experience measures like PREMs and PROMs. I guess they've heard of that kind of language around. Is that what you're looking at?
That's right. So you'll be receiving a provider experience survey link within the next few days. So that is our current focus. We are also working on distribution approaches for a standardized PREM survey, so not PROM. PROMs require some sort of additional specific infrastructure. The focus will be on PREMs. And in both cases, with the provider or the patient experience survey, we have a demographic section that allows us to do those ethnic stratifications, those equity stratifications.
Excellent. Great. Thanks. There are one or two more comments, I think recommendations, suggestions for how to get around some of the power issues that we could have future discussions about. And I think one is like combining data over longer periods of time. I know we're trying to be rapid cycle and having data that is very up to date, but one of the alternatives, for example, is to combine multiple years of data to increase the power. And so the trade-off there is the recency, but there are ways to think about that. So just some thoughts around there. Thanks very much, Ian. Really appreciate it. I'm going to move now over to Darren, Eric, to hear from the kind of front lines people, Ontario health teams. We always like to highlight some experiences of what's actually happening in the Ontario health team. So today we're going to hear from Mississauga and then from Ottawa. Very different approaches and perspectives. But Eric and Dare, I'll turn it over to you.
Thanks, Walter. Okay. So I'm Eric, everyone. So I'm the population health analytics lead at Trillium, where I support analytics for the MOHT, and I'm joined here with Dare, who also supports these activities. So before we get into the real, crux of the presentation, which is going to be focused on how we approach equity measurement at MOHT in the context of performance, I want to provide a little bit more of a context or background on the population of MOHT and kind of how this led to our approach for equity measurement. So at MOHT, we serve an extremely large and diverse population. It's the largest OHT in the province, serving about 1 million people, and is actually expected to grow by 45% by 2041. 1 in 10 of those 1 million people don't currently have access to regular primary care, and then more than 50% of our residents were born outside of Canada. So also Mississauga has amongst some of the lowest rates of team-based care, which is going to sort of remain as a challenge with our rapidly growing population. So in terms of the current state, or at least at the time that this product was being initially discussed, was that we had some limited data availability in terms of it being able to provide some more granular or more OHT-specific results. There was a desire at MOHT to do some more of these sub-analyses and different breakdowns by or indicators by different geographies. For example, we use Peel data zones in the region of Peel, so that was something that we were interested in being able to incorporate. We also did not have any automated processes in place for extracting and transforming and loading different data that we could use for MOHT specific indicators. And then also our ability to report on our local progress and how we're doing and perhaps where we should be focusing on was limited because we lacked that customizable and regularly refreshed data. So really just put more succinctly, MOHT needed more timely data that was tailored to our local needs, our priority populations, and then it could also be used to help better inform some of our decision-making and planning activities, for example, primary care team expansion. So moving on to the solution. So to address these challenges, the team did land on developing our own unique data pipeline and scorecard product that is more tailored for MOHT specific needs and then designed to help enable some comparability with our peer OHTs, track trends, and then really crucially, the really important piece is to monitor and embed equity into all of our different measures. So this product enables us to maintain alignment with OH, so finding that balance between also reporting on indicators that OH is collecting, but also collecting on some other ones that are more specific for our population. We are getting some enhanced insight, so we can refresh that data a little bit more frequently. But then, as I said, sort of tailor those indicators for specific needs. Embedding equity and customization into each of those measures, so really making that a foundation of the measures that we calculate and report on. We're getting that clear line of sight between how progress is happening over time and relative to our peers. And then we're having integrated care support, and that the design is allowed to evolve as priorities change over time as well. And it's really important to note that this work aligns with MOHT's broader commitment to build an equitable and health and wellness system by understanding community needs, reducing barriers, and supporting inclusive organizations, and addressing social determinants of health as well. So here I just want to provide a quick comparison between some of the measures that are being reported at OH, but also some of the differences between our measures at MOHT. So this table does map those different indicators, and in many cases, you are just seeing the categories being the same. Now, for example, CHF and COPD emissions, we have ACSCs in there, cancer screening rates, but also where we differ is where we saw perhaps a need for local insights. So, for example, the rate of ED visits for potentially avoidable causes. This is high priority for THP and MOHT as well. So this is an indicator that we thought was important to collect. Repeat fall-related ED visits amongst those identified as frail older adults, then also percent not rostered to team-based care. So these indicators do reflect our local challenges that weren't captured by data that we had available at the time. And in total, the team did land on 12 key performance indicators that were selected in collaboration with subject matter experts across MOHT. So now quickly getting into our approach to measuring inequity. So I know there was a lot of discussion on the different measures that are available, so I'm not going to get too much into the weeds and relate to the actual measures. But our focus, so the measure of the equity measure that we're using for performance measurement is the Relative Index of Inequality. There has, and again, just in terms of all the different sort of methodology, the only thing that I really want to identify here is that we are using that material resource dimension or the material deprivation dimension of the Ontario Marginalization Index. So that's going to be the main stratifier underpinning the metric. And the reason why we chose RII is because it does allow us to investigate those differences between groups and measures. So it allows us to really identify which areas we should be prioritizing. And I think some of the results that Dara is going to get into is really going to highlight like that advantage of using the RII, at least for our purposes. And again, this is a well-established measure that's used for performance reporting. So really sort of aligning with that learning health system approach that we take. And it's already used by THP leadership and in corporate reporting as well. So this allows us to have that common language and shared understanding when we are addressing inequity. So that's it for me. I'm now going to pass it on to Dara, who's going to get into a little bit more of our results.
Yeah, thank you, Eric. Sorry.
Sorry.
I jumped the gun. No, that's okay. I jumped the gun there. So as Eric set kind of the stage and the context for the motivation behind this project, one of the first steps was to develop the infrastructure, what we're calling this data pipeline, to actually get the data to build this scorecard. And one of the things about the OHT is that we have a unique opportunity with our partnerships between the Mississauga OHT as well as THB and the Institute of Better Health that allows us to build this from the ground up using these health admin data sources. And so we first identified the data sources based off of the metrics that we wanted to incorporate, which Eric showed earlier, which were developed through a combination of our like evidence-based KPIs, subject matter expertise, and an understanding of our local and priority populations. And we were able to work with the Institute of Better Health biostatisticians, shout out to Jimmy, who I'm not sure if he's here, but to pull that data and incorporate it into this Power BI scorecard that we developed, which then we can distribute to THP and MOHT leadership. And one of the benefits of developing the infrastructure, this infrastructure, is that it allows some flexibility in when we get this data and what data we receive, as well as incorporating this equity metric into into the scorecard, not as a standalone metric, but alongside every metric that we measure. And so this is just a quick view of one of the metrics on our scorecard and kind of what's involved. So we have along the top, we have all of our metrics grouped into different categories that align with OHT priorities. So that's our patient flow and chronic disease pathways, our priority populations, among others. We also include some information about how the metric was calculated, so essentially our numerator and denominator. And then some information about the monthly trends and a trend line, as well as the preferred directionality of the trend, whether we want to see it increase or decrease. We have some historical comparators, our year-to-date and previous year-to-date. And then we have some additional comparators. We can see down here is our RII, which is typically a rolling 12-month average. And then we have our most recent fiscal quarter for the Mississauga Health OHT, some peer OHTs, and the province. And so to dive into some of these results, for our most recent data poll, we tend to see, oh, sorry, I don't think some of those colors translated. Decreasing should be in green. But for many of our metrics, we do see that they are decreasing, which is preferred for many of them, with the exception of ACSC hospitalizations for the 10,000 population, which is increasing. We also have some metrics where we don't see much change, particularly in ALC and cancer screening. And we've also included our RII values here. And again, I really want to highlight that ACSC hospitalization. As we saw, honestly, earlier in the webinar, we do see that trend between the number of hospitalizations and RII. We do have a fairly high RII for our ACSC hospitalizations at 4.5. I think this is a particularly interesting result for the MOHT since we tend to rank fairly well in, compared to other OHTs in terms of our ACSC hospitalizations, but we still see this strong equity gradient among this particular patient cohort. And so this really does present an opportunity to us for developing tailored interventions to support this population. I'd also kind of highlight maybe our ED visits for potentially avoidable causes and our percent of ALC days here as well, which have a bit of an equity gradient too. So again, just to kind of quickly summarize, we saw this need for data that is tailored to our population, that is accessible to us at a relatively frequent cadence to better support the decision-making at the Mississauga Health Ontario Health Team and track our trends over time. And in line with kind of the ethos of the OHT, we sought to integrate an equity metric, RII in this case, as an inherent aspect of each metric, not as a standalone indicator to better support and understand our population. And I think it really kind of drives home that idea that some of those results, like our ACSC results, that you really can't have that performance improvement or these performance analytics without taking into consideration equity to really get the full picture of your results. And we do see that many of our metrics exhibit some level of an equity gradient, but there are stronger gradients in ACSC, ALC, and our avoidable ED visits. And for us, our next steps are really looking at what existing or potential future OHT initiatives can we develop that can maybe help move the needle on some of these metrics, as well as developing a target setting methodology to really find a quantitative way to track these changes in our indicators. And just to wrap up, I'd also just like to quickly thank THP and the OHT and the Institute of Better Health for their support with this project. It really would not have been possible without them. So thank you.
Wow. Thanks so much, Dare. Thank you, Eric. I don't know about other people, but I think some people out there might be sort of feeling a little bit jaw-dropping about the capabilities and resources that are being drawn on for the Mississauga Ontario Health Team. I think perhaps it's something that comes a little bit at scale, although I don't know that OHTs that are larger get more money than others. But clearly leveraging some some strong advantages. And I think it'd be interesting to know about other OHTs. I have seen some dashboards. I know, for example, we recently had South Georgian Bay join us in the fall in November around performance measurement. And they have like an online, like a public facing one as well as an internal dashboard. I'm not sure they're doing equity measurement, but I really commend you for advancing this equity measurement as part of your internal performance measurement. And I think it's a really nice example for other OHTs as they are thinking about moving towards looking at performance measures and even pulling from the ones that are on the Ontario Health dashboard to make sure that they are also including those equity measures. So I think it's about pulling things from where you can, not necessarily everybody being able to drive their own internal data and dashboard. And Wendy from, I'm not sure if you're familiar with Wendy, but Wendy Jerry leads a lot of data for and supports many of the Ontario Health teams. She's looking to reach out. So one way or another, you can get in touch. Oh, there you go. You got it. You guys are on top of this. If there are any other questions, be really happy to hear what they might be. And I'm going to ask Lee, I think Adam's got a question here. She put it for VJ, but you just had a slide up that had a whole list of RIIs. Adam's asking about the interpretation of the RII. I don't know, maybe you want to pop back to that slide and once more sort of, like here, like what does 1.61 mean? Or 4.54? Like what do these numbers mean?
Yeah, so for the RII interpretation, again, as we kind of touched on earlier, it depends to an extent on the directionality of your metric, but I'll use ACSC as an example where we are looking more ACSC hospitalizations is not preferable. We want to reduce that. And so in this case, the RII of 4.5 means that we're seeing that individuals from higher deprivation are about 4.5 times more likely to use these experience like ACSC hospitalization. And so that is how you would interpret it. For something like breast cancer screening or cancer screening in general, it would be the opposite in the sense that we want higher numbers in those metrics. Eric, anything to add on to that?
Yeah, the other thing that I would add on here is that maybe a slight point of confusion is that for our screening rate, so where it's like more is advisable, there was like we sort of inverse the relationship so that way like it's more interpretable. So that's just like a slight kind of differentiation. So maybe to be aware of, especially those that are exploring different measures, to look at how these are reported and calculated. Because in this case, it would look like a positive RI value would still mean that there's higher inequality. So it's just because that relationship was inverse for interpretability.
Yeah, it's very important. And I'm going to bring up a slide at the end that we had actually added into the last second of the deck, but we missed the right one. So I'm going to put it up. We actually will include in the deck advice to everybody when you're looking at both the directionality of the indicator and the directionality of the stratifier. They both play a role as to whether things are better or worse. But the actual interpretation, like 1.6 means it's 60% higher at the highest end of whatever scale you're using as compared to the lowest end. That's Dare, you said 4.5 times 450% higher. That's the interpretation of the actual RII measure. So thanks for that. Okay, so we are now going to turn it over to a different perspective, and they've got dashboards and all kinds of stuff up in Ottawa, but they've actually got a long history with the Ottawa Neighborhood Study, which they've really been leveraging in their OHT's work. And they've been looking at equity and looking at neighborhoods in a slightly different lens. So I'm going to turn it over now to Shelley Horrocks from Ottawa to talk about how they are thinking about, and actually, the so what, like how they're actually using the data to reach out and plan their work. So I think it's going to be a great interest. Thanks, Shelley.
Awesome. Thanks so much, Walter. And thanks to have you all here on this lovely, very chilly Tuesday where I am in the world in Ottawa. All right, so as Walter said, I'm going to be talking a little bit about how we use health equity data in our decision making. So all of this other stuff that we've talked about already has been really helpful for our OHT in understanding that while we perform relatively well, as an average, when it comes to things like cancer screening and other indicators, we also have like very high inequality between our most socioeconomically vulnerable and privileged neighborhoods within our OHT. So there's lots of work to do to close those gaps. So we have the privilege in Ottawa of being co-located with the Ottawa Neighborhood Study, and a few other resources which provide very rich local place-based data. So the Ottawa Neighborhood Study works collaboratively with a number of local organizations and community members themselves to draw neighborhood boundaries that are reflective of real communities, and allow for rich like statistical analysis still. So they maintain large enough sizes that we can actually work with that data and avoid too much small cell size issues. They also work with the Ontario Community Health Profiles Partnerships, OCHPP, and so we can get some data from them at that same geography. And at the city level, we can also get some data from like Ottawa Public Health, police, and a number of other organizations at this same geographic level. We also have another resource, the Neighborhood Equity Index, although this is outside of the Ottawa Neighborhood Study System. So I'm going to leave it for now, but they are also a very interesting resource if you're interested in looking into them. So some of the benefits of ourselves and a bunch of our partners being on the same place-based system is that we can jointly understand our community's unique, our city's unique communities and their needs, use the same simple language in our collaborative planning. When I say Sandy Hill, everybody at the table knows where I'm talking about. And we can really drill down into talking about what the needs are there and which communities we're talking about. If I say ADA 56092, whatever it is, that's a lot harder for people to come together around, rally around, and understand. And this also allows us to integrate lots of data, health outcome data, system usage data, population health, and social determinants of health, all from a number of sources when we're using the same system. So we have StatsCan data, data from Inspire through OCHPP, HSPN data, and we're working right now with our hospital partner, TOH, and the other hospitals in our area so that we can have a data pipeline to get hospital level data from all of those hospitals at this same geographic level as well. So that's gonna, yeah, we're very excited about that moving forward. All right, so this is just a little example. We know from looking at our community that standard geographies like aggregate dissemination areas or FSAs, which are, for the Postal Service, these don't necessarily reflect real communities and often actually hide equity and health disparities. So on the left here, we have an ADA, and when we look at a bunch of health indicators and marginalization and equity indicators for this ADA, it comes out as pretty average across the board. When we look though and break it down into real neighborhoods, we can see that on the left in Billings Bridge, we actually have one of our most socioeconomically vulnerable neighborhoods. And on the right, Alta Vista, one of our most socioeconomically privileged neighborhoods. And there's quite a big difference in the population groups and health system utilization between these two very distinct neighborhoods. So our OHT loves place-based planning, and so in our recent work around interprofessional primary care team expansions, we developed a primary care dashboard for OHT partners utilizing a lot of place-based data. So we have here our primary care practices and their sizes for our geography of responsibility. And then we have some primary care attachment indicators. We were able to get some age segmented attachment indicators through our partnership with HSPN for these neighborhoods, which allowed us to see that there was a big difference in attachment rates across age groups by socioeconomic vulnerability. In the neighborhood, we could see that in our most socioeconomically vulnerable neighborhoods, the rate of unattachment for children under 6 was much higher in that age group specifically, with I think our Q5 neighborhoods were like 1 in 3 children under 6 were not attached to primary care on average. So that tells us, we need to be doing some work in these neighborhoods for better attachment for newborns and young children. And then we integrated as well some population health data, focusing on our priority populations, sociodemographic data from the census, and some social determinant of health data as well. So, in looking at this, I'm going to go back to these 2 neighborhoods here. So again, Billings Bridge on the left is one of our socioeconomically vulnerable neighborhoods, and Alta Vista on the right, one of the most privileged. So when we look at unattachment for this ADA, we can see it's pretty average, about 16% of the population there is unattached to primary care. But when we break it out, we can see that in Billingsbridge Heron Gate, it's actually much higher. So about 23% are unattached versus about 14% in Alta Vista. And the age groups there also differ a little bit as well. On the right there, when we look at cancer screening as well, we can see in Billingsbridge Heron Park, almost half, about 46% of eligible people are not up to date with their breast and cervical cancer screening, where that goes down quite a lot to 32% in our more privileged neighborhood. So, and again, that's a percent of residents not up to date. So the higher the number, the worse it is. And we can see this reflected very clearly across all of our neighborhoods. With our most socioeconomically vulnerable having much worse screening rates. So once we identify those disparities, what are we going to do about it? So we look at our breakdowns of some sociodemographic factors. On the left, we have Heron Park and Billings Bridge are socioeconomically vulnerable. And we can see that the breakdown is very different in the demographics compared to Alta Vista. So the percent living in low income is like 23 versus something like 4% in Alta Vista. Our percent of racialized residents is much higher. It's 38% versus 22%, and specifically a much higher proportion of residents who identify as Black in Heron Park, Billings Bridge compared to in Alta Vista. So there are some considerations there for our planning. If we're looking at doing cervical cancer pop-up clinics, we need to be considering that most people are probably relying on public transit. Do they have limited work hour flexibility? Are there childcare challenges? Do we need to have a childcare friendly space? Are there actual risk disparities between different populations that we need to consider? And what are we going to do about cultural safety and developing close partnerships with organizations who are already working and have trusting relationships with residents here? And then we can also use some social determinant of health data from the Ottawa Neighborhood Study to see some barriers and enablers. So we can see in Billingsbridge Heron Park, about 28% of renters are living in subsidized housing. So are we going to advertise our pop-up clinic at all of these buildings with that housing partner? Are we going to host them in the subsidized housing buildings? Is there a cluster there where we can do a pop-up clinic specifically for that population? Similarly, we can see that quite a high proportion of residents live within a 15-minute walk of the local CHC. So are we going to host our clinic at the CHC and arrange transit options, shuttle buses, to subsidized housing buildings that are outside of that radius? What are we going to do to further enable populations there to be able to participate in our initiative? So I get excited about this. This is the stuff that we love to do with this data. And I think, I guess if I had to share a takeaway, something that we find the most valuable is having those small shapes, those neighborhood shapes in Ottawa that we can all get on the same page with. So if you have any opportunities to develop neighborhoods with your partners, doing that in collaboration is so helpful. Um, yeah, I would just say that it's a huge boon to our planning. And if anyone has any questions, please feel free to shout it out or send me an email as well. You can let me know. Thank you.
Hey, Shelley, thanks very much. Really appreciate that. And you're getting a lot of shout outs in the chat as well. People are happy to see your work. Congratulations. And you know, really the thoughtfulness and approaches, lots of, love to see your work, thanks for sharing. Looking here for people. There was a question around how often you're able to update your data sources.
Absolutely. Thanks, Walter. So it depends on which source we're talking about. It is a challenge, though, compared to using like FSAs, which are available sometimes quarterly or bi-quarterly from the OHT dashboard. It does limit us a little bit. So we're reliant on like the census itself. So right now, all the census data we're using is from the 2021 census. Although with our partnership with the Ottawa Neighborhood Study, once the new census data comes out, we'll be able to get the extract of that and replace everything with the up-to-date census data. Um, with the partnership with Epic, with the Ottawa Hospital and other hospitals in the area, eventually that's a work in progress. That would be much more up to date. We would be able to do that. I mean, however often we would want, because it would be up to date to the day. Um, yeah, so it really depends. Like data from OCHPP is usually on a 2-year cycle. So it gives a really great point in time look at what's going on, but it's not often the most helpful if you're trying to do tracking, like monitoring across quarters. It's less useful for that, although there are opportunities to be using that place-based data with other data sets. So data from the Ottawa paramedics, for example, uses these shapes. So that comes more regularly through requests or through the police. If we're looking at things to do with mental health, substance use, addictions. Trying to think of anything else. And with our community health centers as well, as they're all using the same system. And yeah, so we can fill in their data more regularly.
I think what you're saying also is that all of your data are not timed like perfectly and
Oh,
uniformly and
no.
still.
No, not at all. It really depends on what the use case is for that data, but certainly as a point in time or for every year, every 2 years, very, very helpful. But for ongoing monitoring, there are limitations there.
Yeah. And I think, one of the things coming out today are some of the advantages and, I think we need to think about how we help OHTs support with academic and other partnerships, right? Like I think the Ottawa Neighborhood Study is a partnership with Claire Kendall and others at the, University of Ottawa who've been doing this a little while. It also helps with, some of the supports that can come from CIHR funding and external sources, right? That helps. I know you've been at this a little while. Yeah, also, overnight success. It takes several years to become an overnight success for people
Yes.
watching both, what Mississauga has been doing and what you're doing. Is we're showing, what you can be, but just for people to be aware that, if you set the vision, it can still take time, but you sort of decide what it is and that's important and then build that with your partners. Um, and I really liked your view of intersectionality as I'd view it. You look at a neighborhood, you're looking at 6 or 7 different dimensions at the same time on the same. And there are others suggesting in here. I'm conscious of time. You got a couple questions here. Maybe you can see which ones you might be able to answer quickly. But I want to bring everybody back here. Maybe we can just let people know. I'm going to take one last poll. So maybe we can bring up this poll on the measurement approaches used today. Which do you think are useful for OHTs? And Tricia, you might have had this in as the third poll because I think, yeah. So if you can bring that up. And the idea here is that, you'll get a poll and you'll be able to select and say which of them, and you can choose as many as you think are useful. And we're kind of interested to see like, are there some that really kind of, pop out, most useful, least useful, and we kind of have a little bit, so like more descriptive, like we talked about at the very beginning, or how Ottawa has done their work. Some of the stratified approaches. Do you think slope indices are the way to go? And you can think all of them are useful. So I just want to get a little bit of a sense here before we pop off. But we had some pretty fantastic attendance here. We picked well over 250 people at just before the 1 hour mark, which is, we do an hour and a half because there's too much content to fit in an hour, as people saw again, but we still have like almost 200 people online today, well into the event. So that speaks to the interest, the capacity, and I say people come here for the content and they stay for the chat. So I think people are really recognizing the important work that Ontario Health is doing, that Mississauga is doing, that Ottawa is doing, and really appreciate your. We're also at HSPN aiming to support teams. Okay, we could share these results back out just so people have a sense. So pretty high rates, like 76%, liking that descriptive. So really hitting home there. And then thinking about this relative index, comparing across, also having, quite high. And then, stratified and slope index being just behind there. So everybody, I think more than half of everybody thinking all of these are useful with, I think bringing it meaningfully back to the neighborhoods and the way we can actually work with people locally and our communities is most important. We can bring that down. And I will thank our many participants. So we are at time actually now. So I welcome everybody. We had an extra discussion, the type of supports that you want. We'll be interested to hear that maybe through the feedback questionnaire. We are going to pop out. You'll get a questionnaire just about what you thought about this and ideas for future webinars. We are here the fourth Tuesday of the month. Almost half of you are new this time. We're here every month. Watch for us. We'll be doing some performance measurement. Actually, next month, we might also, because we're dancing up one of the next 2 months, we're also going to have a special issue on climate sustainability and Ontario Health Teams and sustainability of integrated care, population health, and our climate, as I see the sort of most existential issue of our time. Thank you for everyone participating today. I wish you all a lovely afternoon. Particularly thanks to Ian and VJ, Dare, Eric, and Shelley for sharing today. Have a great Tuesday afternoon in however much snow you might have today.